Welcome to this special interview with Dominica's Director of Primary Healthcare, Dr. Laura Esprit. Dr. Esprit led the team of primary healthcare workers who are at the forefront of the fight against COVID-19. The primary healthcare workers were responsible for contact tracing to identify cases of COVID-19 in Dominica and to stop its spread within our community, certainly playing a very important role in Dominica's successful efforts to contain the virus. Dr. Esprit, hello and welcome.
Hi, thank you. It's a pleasure to be here.
I wonder, when we talk about primary health care, what do we mean?
Okay, so as the name indicates, primary means first or initial. So it's that first level of care that, for example, if someone requires some type of health intervention, then that would be the first level of health care that would be available to them. When we think of the hospital would be secondary level of care. So primary is really that initial contact with healthcare providers. In Dominica, our primary healthcare system, we have approximately 49 facilities making up primary healthcare in Dominica. We have health facilities that we term it as type 3 or the bigger health centers versus the type 1 health centers that are the smaller health centers, right? So we have around 49, as I said, 7 of the type 3, and that's the main health center in every district, versus the smaller health centers that are scattered around the district. So if somebody is ill, if somebody is sick for whatever reason, then that would be their first contact, first level of care with nurse, with doctor, community health aide. So basically, in a nutshell, that is what we refer to as our primary health care, and it's really a flagship in Dominica. It's a model of care that we do practice. It's primary health care.
Mm-hmm. Talk to us about your role. What are some of your typical daily functions as Director of Primary Healthcare Services? Okay,
so that's a very interesting one because it spans, it takes a large span, so to speak. As the word director suggests, basically what I do, or the director would direct, organize, manage and control healthcare delivery at that primary healthcare level. I would actually orient new doctors to primary healthcare services. I would supervise the existing ones and the district teams by extension. And in addition to that, there would be cases where we would have to identify any gaps or deficiencies as it relates to healthcare delivery and actually find ways to monitor the services and to basically to supplement, to mitigate any types of gaps or deficiencies as it relates to delivery of services. In addition to my role of director, I'm also the health disaster coordinator for the Ministry of Health. So that means anything to do with disaster, be it of an infectious nature like COVID-19, or be it of a natural phenomenon like hurricanes, etc., then that would be the role of the health disaster coordinator, which is also attached to the Director of Primary Healthcare Services as well. In addition to that, I'm also the chair for the NEPO Committee, National Emergency Planning Organization, specifically for the health subcommittee. So it's a wide range of responsibilities that is under the purview of the Director of Primary Healthcare Services.
Mm-hmm. As COVID-19 became more an imminent threat for Dominica, what did you begin to do differently as Director of Primary Healthcare to prepare for, or rather ahead of, the first case of COVID-19 in Dominica?
Okay, I must say there was a lot of preparation behind the scenes. It was not simply get up and decide, oh, we're going to fight COVID. There was a lot of preparatory work, and that meant that everybody had to be engaged. So that would have included the doctors, the nurses, the community health aides, the district infection nurses, even the drivers to a certain extent, because, for example, with samples, you would need samples to be transported from one area to the next, and the driver had to be clear as to what his role was. So it took a lot of preparatory work. Initially, what we had though is a plan. We had an ARI plan, or an acute respiratory plan that we had years before. So because COVID-19 is transmitted primarily through the respiratory system, what we had to do is to review that plan and make it into a COVID-19 plan. So we first met as a committee with this, what we call the senior community health nurses, the director, and some of the critical persons in primary health care. We looked at the plan, we saw how we could tweak it, make it into a feasible COVID plan. After doing that, though, we had to take it to the districts now, because yes, we have 7 health districts in Dominica, but it also meant that the districts they have their peculiarities. They're very different. So the plan now was not a one-size-fits-all. We had to tailor it to the needs of the various districts. Some districts, the facilities are different, the staff allocation is different, maybe the resources, the topography, everything is quite different. So we had to tailor that plan that we updated as a committee, but we had to send it across to have the teams review it. Eventually, that plan had to be, yes, reviewed, but also turned into an implementation plan as to how we're going to get this done. It's not something documented on a 200-page document and nobody knows what to do. So that in itself was very challenging. In addition to that, again, I had to put a lot of what we call algorithms together. In other words, if someone, we looked at various scenarios. If someone came in as a suspect case from the port versus someone who became sick at home, how do we transfer this patient? First of all, how do we treat this patient? How do we interact with the patient? And then how we finally transfer that patient to one of 2 locations. And that would have been either the isolation COVID unit at the hospital or the COVID unit at Portsmouth. So all of those preparatory works had to be written and discussed. In addition to that too, we had to ensure that the staff, we brought them together centrally in Roseau to review the plans with them, to discuss the algorithms, the flow charts with them, to get their views on it, if they were comfortable in putting on the protective equipment. And so it took a lot as it relates to preparation. But certainly we thought that it was necessary so that the staff feel comfortable in order to be frontline workers against this COVID pandemic. Even the resources, you can't go to war if you don't have the necessary resources. So all to say that there was a lot that had to be done before or in preparation for the first case, and it took a lot.
Yeah, and then we did record our first case, and your unit, the primary health care services, had to switch to immediate contact tracing. How did you organize a structure for that, and who were the people who were involved in that process?
Okay. So we realized that it could not be in our local parlance, it could not be vai-ki-vai, right? How are we going to get this done and get it done effectively? So as the name suggests, it involved contact tracing and sample collection, right? So we had dual roles to find the persons who may be contact, and when we do find them, we have to ensure that their samples were taken within a time-sensitive period. So we thought of how we could get it done expeditiously, but also effectively. So what we decided to do, the committee would have 2 arms basically. The administrative team that would remain physically in Roseau versus the mobile team who would be liaising with the rest of the team on the ground. Now, the admin team, we had to reassign staff, I must say though. We got the support of the chief dental officer, and what we did, we paired her with the senior or the supervisor, the nursing supervisor for administrative region 1. Because I must tell you though, primary healthcare has 2 administrative regions, 1 and 2. So we paired our chief dental officer, Dr. Idalene John, we paired her with nurse SCHN, Ms. Florestin Lewis. So she would take care of the affairs of Region 1, which is Roseau, St. Joseph, and Granby. Then we had Mr. Lester Guy. He's the coordinator for the National HIV program. So what we did, we paired him up with the senior nurse for Region 2, that is Nurse Alexander Popon. So he could deal with those affairs as well, right? So yes, we were physically in one room, but remember, primary healthcare is technically the entire country.
Yeah.
So we had to find ways for things to flow smoothly. In addition to that, for the mobile team now, we recognized that we needed a team that would be basically ready to be deployed at any hour of the day or night. And to facilitate that, we had the re-engagement of one additional doctor. So in that case, we had Dr. Dionne Durand, and he gave great support to the mobile team. I'm not saying he's the only one, but he was re-engaged particularly for that purpose, right? So he in addition to the other staff who made up the mobile team, would go and give support to the district teams, the teams on the ground. And we refer to it as surge capacity, to give them additional staff to get the work done promptly and properly, right? I must tell you though, that mobile team, we ensured that the teams had a minimum of 3 people. Why 3? Because yes, we had the actual person who was actually doing the sampling. We had the second person who was actually filling up the forms to make sure that the samples were properly labeled, and that's very, very critical, properly labeled. And we had a third person, and we call this person our staff welfare officer, to ensure that when the staff put on the gown and put off the gown, that they don't forget the steps to avoid they themselves from being contaminated. In addition to that, we also had the support of, we had a PS reassigned or assigned to our committee, and that a PS, she's presently the financial secretary, PS Dennis Edwards. So she gave us great support in terms of logistical and non-logistical support. So I must tell you, we had vehicles at our disposal, not necessarily from health, but reassigned from the public service, so that when we tell the team at 11 p.m. we're ready to go, there is no issue on what we're going. So that really, really, really assisted. In addition to that, we also had the support of the fire and ambulance services, because we also needed drivers to drive those vehicles, right? They also ensured too that we always had fuel and the bus was prepared and ready to go every time. In addition to that, we had to find an appropriate location. We have a small conference room. Yes, we took in the concept of physical distancing, but we have a conference room, and that room had our maps, our posters written. We had communication, our phones, our radios, everything that was needed actually to get the job done. So basically, in a nutshell, that's what we had. Oh, I did mention too our clerical team, but that's very, very important to get things done, even to get food for the mobile teams out. And we had additional support coming to primary healthcare to assist us. We had my secretary, that's Miss Regina Thomas, in addition to Miss Shara Georges, who actually came in to give us that support that we needed. So in a nutshell, we had to ensure that we had the resources, we had the personnel, and the motivation to get the job done.
Mm-hmm. And it's important to identify these people who played different roles in the process. I wonder, did you have difficulty with identifying people to fill roles within your structure for contact tracing, in the sense that did you get any kind of pushback? Were people generally receptive to working so closely with potential COVID-19 cases?
To be truthful, initially it was a little tough, it was a little challenging in that, and it's understandable because it was a new disease. Mm-hmm. The reports that we were getting is that it was lethal, right? So the staff, the majority of the staff, they were actually scared. So they were sort of guarded, very cautious, right? And the concern was very much noted. So what we did to mitigate that, though, is to ensure that we had enough training opportunities, Because if you're not too sure of what is coming your way and you're fearful that you yourself may be affected, maybe pass it on to your families when you get home, I mean, it's really terrifying. But what the Ministry of Health did is to ensure that training opportunities were available to the staff and to make sure, for example, with the donning and the doffing of the personal protective equipment. In addition to that, though, what I try to do is to give as much support as I could. Mm-hmm. So, for example, during the first, if not all, the cases that we had, I would ensure that I would walk the staff through the process, right? So, for example, if we heard of there is a case in a particular district, I would call that particular team leader and tell them what to do, how to do it. I would make the calls to the fire and ambulance myself so that they get the ambulance across to the district. I would call the hospital myself, put staff on alert, time it, etc. In terms of contact tracing, as long as I got the numbers, I would call from the office, mm-hmm. right? So that could alleviate some of the anxieties that the team was feeling. And even if I was not physically in the district with them, but we were working as a group, so the administrative leg that remained in Roseau, we were doing as much calls as possible to provide that type of support.
It does sound like some pretty heavy duty responsibility for you as the director of primary health care. Did you ever feel any kind of anxiety, fear? And if you did, how did you manage that as the leader of your team?
Again, honestly, I must say I was not fearful. I was not anxious. Okay. I'm a prayerful young lady, so I prayed for insight and direction, and I did all that I could. That was within my limits, of course. But I must say too, though, that the way things happen. It was happening so quickly that there was no time to be anxious, to be very honest with you. And I must say, though, that maybe my only preoccupation was that whatever we had on paper, whatever we had implemented, that it would go, in terms of actual implementation, it would happen smoothly. I must tell you, though, that in one of the districts, we actually did a simulation exercise. Mm-hmm. I went across to visit a particular district, and we went with a patient who presented with symptoms and signs of what appeared to be COVID, and we allowed the team to, or we saw how the team would have managed the patients. So all of that was in terms of preparation. So what we did to avoid that too is to assign or delegate specific tasks to specific persons. Because if you if you give too many responsibilities to just one person, then you're going to have chaos. Mm. In addition to that too, what we had, especially at our venue, is that we would have daily briefings and debriefings. So on average, would have, let us say, minimum 2 meetings a day. So you have assignments. In the first meeting, we tell you what your assignments are. We decide we're going to meet in 2 hours time, 3 hours time, or at the end of the day, everybody regroup. Maybe the mobile team would be back, and then everybody give their report. Where are we? How many districts have or may not have personal protective equipment? What about swabs for testing? Where are we on that? What are your challenges? How many persons for contact tracing? So those meetings, the briefings, etc., it really helped. In addition to that too, as I said, the staff welfare bit, I must say that was a preoccupation I had, because it won't be easy to be in the line of duty and you become sick yourself. Mm-hmm. I thought about it, and again, that is why we decided that we would send no less than 3 people out, because that one person is very, very critical. Because maybe during the event or during the process of doing the swabbing, etc., it's easy to forget. You would have been trained, yes, but from human error, you may forget. Mm-hmm. So that staff, that welfare person was very critical to the team, and we ensured that that person was present. Another concern too, in terms of maybe the preoccupation that I had, was in terms of timely deliberation. And I must tell you though, some of my staff, they were not pleased with me because of that. But I thought it was very, very critical. I mean, the time between you actually finding out a patient is positive to the time that the patient is actually at the COVID unit. That time is very critical. If we decide to delay, you know, let us do everything else we have to do and we'll do it later.
Yeah.
What happens to that client? What if the client leaves home, goes to interact with neighbors? That means you have a lot more people in a community for you to do contact tracing for. It's easy to transmit the disease that way. It's highly infectious. And that time-sensitive nature was at the forefront of my mind, and I was very eager from the time results were in. It was like, let's get everybody mobilized and get the patient moved immediately. So that was, I must say, it was not anxiety, but certainly a preoccupation that I had.
Mm-hmm. And from the outside looking in, it does seem that the work was continuous over a sustained period. And so it seems to me that some of your members of your team may have experienced burnout. Did you account for that? Did you put measures in place to deal with that? And I'm getting the impression that you probably did.
Yes. So the interesting thing about it is that COVID, the pandemic didn't start, and the other responsibilities of primary health care dissipated or was put on aside or was put on hold.
Certainly.
We had to be dealing with the routine events of primary health care as well as other, because people were still getting sick.
Of course.
Your blood pressure might be high, your sugar might be high, and we still had to treat those people. So certainly the staff, I must tell you that the staff was burnt out, and it was very challenging for them. So what we did though is to, first of all, we had to scale down on some of our routine activities like home visits, household visits. We had no choice but to scale down on those, right? We had the COVID, you must have heard of the COVID hotline, mm-hmm. so that we could capture staff, not staff, but patients at home instead of having them come to the health center. So in that case, the doctor or the health personnel would have some type of interaction with them instead of having them physically come to the health center. In addition to that though, we had the staff. We did it in such a way that we would have given them some type of respite, at least a few hours, a few days, a day, to catch themselves, to recuperate. And to be honest with you, I must pause here to commend the staff. It has not been easy. It has been very challenging because there is a physical component to the pandemic, but there's also a mental and psychological component as well. I mean, to be at the front line, to be dealing with persons who are sick generally, but persons who are suspected to have the disease, to deal with the anxieties at home, maybe the children, well, not maybe the children are home, mm-hmm. and maybe a little anxious, and it was additional stress for the frontline workers. And I must stop to commend them that they did a tremendous job collectively, every category of staff, and I never stop to say it, it's really every category of staff. We cannot forget the drivers, even the cleaners,
of course.
Because if the place is not clean, then what happens? So really and truly, I wish, as the director, I wish I could do more. I wish I could tell staff members, you know what, take a whole week and rest yourself, you know, take a vacation. But again, because the other conditions have not been put on pause, then we're right there at it. We're right there at it. Following directly from that peak that we had a community testing aspect, and again the team was on the ground again. So it really, really took a lot, and I believe that the staff has done a tremendous job, even with the constraints that they had. Mm-hmm. For me personally, I must tell you to date, I'm still very tired. I'm sure. That is my honest answer. But again, we have to do the job. We have to get it done. And for me, what keeps me going really and truly is the love for love for people. Right?
You mentioned the community testing, and we have completed that. What was the general response of the public during that process and during contact tracing? How did they respond in general to your staff?
Okay. So generally speaking, the majority of the staff were, not the staff, sorry, the community members, they were very receptive. They were happy, they were thrilled about the idea. We had little concerns here and there, but I must say persons were anxious to get it done. And we had what we call a sampling size, a sampling list of specific names that we needed to test actually. And persons who were not on the list were actually expressing a desire to actually be tested, but unfortunately we could not test everybody. But generally they were pleased, they were happy. They actually, well, the majority actually preferred the blood test versus the nasal swab.
Of course, I'm sure.
Some person said it's as if the swab was going into the brain, but generally it was well received.
If we're faced with a second wave of COVID-19, God forbid, and I am aware that we have 2 active cases in quarantine, which seem to be contained, but if we were to face a second wave, is there anything you would do differently in structuring your primary healthcare response?
Well, that's an interesting question, but to be honestly, I think we did pretty well. I would continue the same measures, the same structure. I would definitely factor in respite for the staff, but in terms of the level of the community though, what I would suggest is to have mandatory home quarantine. Mandatory, almost like you have to stay home, because what we saw initially is that persons who were coming into the island, or persons who were exhibiting some type of symptoms, would ask them to stay home for 14 days. And before you know it, you would see them on the streets, at the supermarkets, etc. So if there is one thing that I would add or recommend, it would be that if we could find a way, maybe it might be challenging because really and truly, can you really force persons to stay indoors unless if it's a national curfew or something like that. But that is what I would recommend, that the home quarantine be made mandatory, so that when we tell you stay home for 14 days, you actually respect that and remain home.
I wanted to ask you, the strength of our primary healthcare system has been applauded, and this is not new. We've always had a pretty strong, advanced healthcare primary healthcare system in Dominica. What do you think accounts for that? And of course, we saw that come into play with the management of our COVID-19 response. What do you think accounts for strength within that sector?
Okay, so Dominica has a very dynamic health system. As I mentioned at the outset, that our primary healthcare system is a flagship, and it's recognized not just nationally but regionally and internationally as well. So on that merit, the primary healthcare structure needs to be applauded. The structure that we had pre-COVID, in terms, for example, we have 7 health districts. It's separated. There are teams at each health district. The teams would know who the clients are, what they suffer from, where they live, their contact information. Likewise, the populace in that district would also know where the health center is, what's the nurse's name, doctor's name, where do I find them, where they live, etc. So that is certainly important. In addition to that, primary healthcare, and by extension the Ministry of Health, we have wonderful collaborators and stakeholders. So our relationship with the police, with fire, with other NGOs, with other ministries, that in itself is quite unique. Our relationship with the police in terms of ensuring that persons remain at home, that persons adhere to the curfew and even to the quarantine at our quarantine facility. So all of this component really supported our fight towards COVID-19. And again, in terms of our preparation, I cannot not talk about preparation or the preparation that we went through with any phenomena when we heard about Ebola. The same effort that we put into preparation at the various through the various categories of staff, I think that also attributed to our strength as well. But in addition to that, I must say the commitment and support that we got from the cabinet in ensuring that the resources that we required was available and always on time, the support, the motivation, the presence, that too played a key role, I must say.
Mm-hmm. You mentioned earlier that you were the chairman of the health subcommittee of NEPO. As we go through the hurricane season, how do you balance planning for possible disaster with continuing COVID-19 concerns?
Okay. So interestingly, this year we are at a disadvantage in that we have a very active hurricane season and we have COVID-19 superimposed on top of that hurricane season. So that leaves us at a disadvantage. Again, it comes back to preparation. Preparation is very, very critical. Now, the interesting thing about, I like to call it the COVID season, because you have COVID and the hurricane season. Mm-hmm. So in that, our plans would have to include both phenomena, that of the hurricane and that of COVID-19. So you would see that a reflection of that in terms of our disaster plans, looking at both components in terms of our assessment of our facilities. And this year that would include the isolation unit at the hospital for isolation and COVID unit, the COVID unit at the Portsmouth facility as well, and even our quarantine facilities. So we'd have to assess those buildings in the event of a storm as well. In addition to that, we look at surge capacity, not just to respond to a hurricane, but in the event that our numbers go up during a storm, right? We have a database that we're putting together as to who would be sent to support COVID patients versus if there are patients who may be traumatized, etc., at the district level. In terms of our supplies, our stocks, and a very critical component, public education. We've been on a campaign, particularly with the support of the Health Promotion Unit, in addition to primary healthcare staff, even persons from local government. We've been on a campaign for the last few weeks to educate the public. But I must pause here, though, to mention that we've highlighted it before, and we cannot stop re-emphasizing the need for family plans. Okay. Because as we mentioned, be it COVID, be it hurricane, earthquake, fire, etc., if the frontline workers have to leave to go and support the public, to be at the health centers, to be on the ground, and they never give consideration to their families, to the kids, what happens if I'm in Roseau and the kids are at home and we get separated, where do we meet, etc. So that family plan is very, very critical, and it cannot be underemphasized. So essentially we're looking at the two components concurrently, that of the hurricane season, and if we have flooding and whatever else, in addition to our response, our national response to the COVID-19 pandemic.
All right. Dr. Esprit, before we end, I wanted to address what we see as a sudden lack of concern or diminishing vigilance now that we seem to have gotten the COVID-19 pandemic under some control. Are you concerned about that? What is your advice to the public in that regard?
Yes, I am concerned. There is an air of complacency. We've done it, we've won the war, we are okay. I mean, I've heard persons say we are COVID-free. But remember, this is not an epidemic. This is a pandemic, which is a global situation, right? And even if we've done very well to contain the transmission of COVID-19 in Dominica, we cannot underplay, we cannot be complacent in our efforts. We cannot think that this is over. It is not over. As a matter of fact, I believe we're going to have COVID around for a little while in the air, regionally, internationally. So what I would encourage the public to do, though, is to keep your guard up and do not make all the gains that we've gotten for the last few months just dissipate, just go out in vain. No, no, no. We want to continue wearing our facial barrier or some type of mask when we're in public, the cough etiquette, and all of those important things that we've mentioned, the guidelines by the Ministry of Health, all of those things that we've educated the public on. Be very vigilant. A concern that I do have is persons who may be coming in illegally through our back doors. It's unfortunate that we cannot close the back doors. I think if we could, it would have been closed by now. So that is a concern that I have. We have to think that our health is our primary responsibility, and we also have the responsibility of reporting those who may come through illegally. Why? Because we're concerned about their health, their family's health, our health, that of the community and the country by extension. So we want to encourage the public to continue those guidelines, continue observing them, including the physical distancing, and do all that we can to remain alert.
I think this is a good note to end on. Dr. Esprit, we thank you so much for joining us, and we congratulate and thank you and your team for the work you've done during this period, and we wish you the best going forward.
Thank you. It's been a pleasure.
Thank you so much for viewing.